All right, let's unpack this. You're tuning into the deep dive, and today we're focusing on something really essential for anyone going into medicine.
Absolutely.
Especially if you're following along with KMR advice. We're talking about ophthalmic mydriatics.
Pupil dilators, yes.
Think of this as a focused session, kind of like you'd find on KMR advice, to really, nail down how we examine eyes using these meds.
Exactly. It's not just about making the pupil bigger just 'cause. It's about getting that crucial window into the eye.
Right. For diagnosis, for treatment.
Yep.
So our mission here is pretty straightforward, to give you a clear, concise understanding.
Yep. The uses, the classification.
Mechanisms of action, and importantly, the key things to consider for using them safely and effectively.
And we're basing this on the source, ophthalmic mydriatics, uses, classification, and management. Sticking to the facts.
Good stuff. And like always, we'll try to connect the dots, make it make sense, highlight what's really key for your learning.
Mirroring those KMR advised discussions.
Okay, let's jump right in. The why, when, and, why do we actually reach for these mydriatic medications?
Well, the most common reason, really, is for ophthalmic exams. Routine ones, diagnostic ones.
Okay.
By dilating the pupil, we get a much better view of the fundus.
The back of the eye.
Yeah, the retina, optic nerve, blood vessels, all that. Our source really emphasizes this for screening conditions like diabetic retinopathy.
Where seeing those tiny changes early is critical, right?
Absolute most sight-saving, potentially.
Okay, that visual access makes total sense. What about other situations?
They're also indispensable in surgery. Think cataract surgery.
Okay.
You need a really well-dilated pupil, gives the surgeon the space, the view they need to do those delicate steps.
Right, makes the job possible.
And same for a lot of retinal surgeries, too.
So, crucial for looking and for operating inside, any therapeutic uses beyond just seeing better.
Yeah, there are. In managing uveitis, that's inflammation of the eye's middle layer.
Okay.
Mydriatics actually play a therapeutic role there. They help prevent synechiae.
Synechiae.
Yeah, they're like adhesions, sticky bits between the iris and the lens.
And those cause problems.
Big problems.
Yeah.
Can lead to complications like increased eye pressure. So mydriatics help stop that from happening.
That's a really smart preventative use. And I remember something about using them for, figuring out glasses prescriptions, especially in kids.
Exactly. That's cycloplegia.
Cycloplegia.
It's the temporary paralysis of the ciliary muscle. That's the muscle that focuses the eye.
Okay.
So by using cycloplegic mydriatics, atropine is a key one here. Especially in children, we stop the eye from accommodating, from focusing.
Which lets you get the true measurement.
Precisely. A really accurate measure of the refractive error, making sure the glasses prescription is spot on.
Okay, wow. A really diverse set of uses then. So how do we actually group these different mydriatic agents?
The main way to classify them is based on how they work, their mechanism of action, and that splits them into two main groups, anticholinergics and sympathomimetics.
Anticholinergics and sympathomimetics. Okay, sound a bit complex. Can we get some examples for each?
Sure. For the anticholinergics, think atropine and tropicamide. Those are the big ones.
Atropine, tropicamide. Got it.
And you might see them under certain brand names. Our source mentions that in India, for example, you'll often see atropine sulfate and midriasil for tropicamide.
Oh, that's useful, knowing the local names.
Definitely helpful in practice.
And the other group, sympathomimetics.
The main ones there are phenylephrine and epinephrine.
Phenylephrine, epinephrine.
Oh,
Okay.
again, brand names might be phenylephrine, HCl, or epinephrine for epinephrine in some places like India. And the source also mentions combination drugs.
Like mixing them?
Yeah, like cyclomydrol, which combines cyclopentolate, that's another anticholinergic, with phenylephrine.
Interesting. So two main buckets, but with different drugs inside having their own characteristics. What are the key differences between these two groups?
Okay, let's start with anticholinergics. Atropine, as our source notes, is known for its really long duration.
How long?
Can last up to a week, maybe even 10 days sometimes.
Wow, that's long.
Yeah, which makes it good when you need that sustained cycloplegia, that focusing paralysis, even though it means blurry vision for the patient for a while.
Useful in certain kids' conditions, maybe.
Exactly. Now, tropicamide, on the other hand, is much shorter acting,
Right.
usually around 4 to 6 hours. That makes it much better for routine eye exams.
Right, you don't want patients blurry for days after a checkup.
Precisely. You want the pupil back to normal reasonably quickly.
That makes sense. Practical difference. What about the sympathomimetics? Phenylephrine.
Phenylephrine is what we call a selective alpha-1 adrenergic agonist.
Alpha-1 agonist. Okay.
Basically, it targets one specific type of receptor that responds to adrenaline-like signals.
Right.
So the main effect is pupil dilation mydriasis with very little effect on that ciliary muscle.
So not much cycloplegia, less blurring of focus.
Minimal cycloplegia, yeah. Epinephrine is also a sympathomimetic, but we don't use it as much topically for dilation because it can have more systemic side effects.
Okay, got it.
Yeah.
Different tools, different lengths of action, different effects on focusing. Now let's really get into the nitty-gritty. How do they actually work? The mechanism.
Yeah, this is where understanding the receptors is key. Let's take anticholinergics first, like atropine.
Okay.
They work by blocking muscarinic receptors, specifically the M3 subtype,
Blocking M3, where are those?
on two key eye muscles. The iris sphincter muscle,
Which makes the pupil smaller,
exactly, and the ciliary muscle.
which handles focusing.
Right. So normally, acetylcholine hits these M3 receptors, causing the sphincter to constrict the pupil and the ciliary muscle to contract for focusing.
Okay.
Atropine blocks those receptors, throws up a roadblock, like you said earlier.
So the signal can't get through.
Right. So you remove that constricting influence, and that lets the iris radial muscle, which is controlled by the sympathetic system, take over unopposed.
And the radial muscle pulls the pupil open.
Exactly. Leading to mydriasis pupil dilation, and because it also blocks M3 on the ciliary muscle.
You get the cycloplegia, the focus paralysis.
You got it. Both effects from blocking that one receptor type.
Okay, clear. Block constriction, let dilation happen, block focusing. Now, what about the other side? These sympathomimetics like phenylephrine.
They use a different strategy. Phenylephrine, we said, is an alpha-1 agonist.
Right, it activates something.
Exactly. It directly activates the alpha-1 adrenergic receptors. These are located right on that iris radial muscle we just mentioned.
The one that pulls the pupil open.
The very one. These receptors are part of the sympathetic nervous system pathway.
So instead of blocking, it's like hitting the gas pedal for dilation.
Perfect analogy. Activation stimulates that radial muscle to contract. And since its job is to pull the iris outwards.
Mydriasis, pupil gets bigger.
Correct. And crucially, because phenylephrine merely hits these alpha-1 receptors in the iris, it doesn't mess much with the ciliary muscle.
Meaning minimal cycloplegia.
Right. Minimal impact on focusing.
Okay, let's recap that mechanism bit. Anticholinergics block M3 receptors dilation plus focus paralysis. Sympathomimetics activate alpha-1 receptors and dilation, minimal focus paralysis.
Nicely summarized.
Got it. So what are the clinical effects we actually see from these mechanisms?
The two big ones are mydriasis and cycloplegia, just as we discussed. Mydriasis, the bigger pupil.
Gives us that wider view into the back of the eye.
Exactly. Essential for checking out the retina, diagnosing, monitoring things.
Like we said at the start, for diabetic retinopathy on KMR advice.
Vital for that. And then cycloplegia, the focus paralysis.
Is key for getting those accurate refractive measurements.
Especially in kids, yeah. Their focusing system is super active, so you need to quiet it down to get the true reading for nearsightedness, farsightedness, astigmatism.
Makes perfect sense. Okay, those are the goals. Now, how do these drugs behave once we put them in the eye? Let's talk pharmacokinetics. Onset, duration, metabolism.
Sure. Our source gives a good overview, atropine. It's a bit slower to start.
How slow?
Takes maybe 30 to 60 minutes for peak effect. And the duration, as we said, is long, 7 to 10 days.
Wow. And how's it broken down?
Mainly by the liver. Now, tropicamide is faster.
Okay.
Onset around 20-30 minutes, and duration much shorter, 4 to 6 hours.
Also liver metabolism?
Also primarily liver, yeah.
Yeah.
Then phenylephrine, onset is pretty quick, 10 to 30 minutes.
And then duration?
Around 3 to 6 hours. Similar range to tropicamide, maybe a bit shorter sometimes. And its metabolism is different.
How so?
It's broken down by enzymes called MAO, monoamine oxidase, and COMT. These are enzymes involved with neurotransmitters.
Okay, MAO and COMT. Good to know. So having those timelines is obviously super important for choosing the right drug.
Absolutely.
Yeah.
Deciding which one fits the clinical need.
Now, any clinical pearls? Those little bits of wisdom we should keep in mind.
Yeah, a couple of important ones. With atropine, really avoid it in infants younger than 3 months.
Why is that?
Big risk of systemic toxicity. The bodies are just much more sensitive.
Okay, definitely something to flag for the KMR Advise audience. Very young infants and atropine, close caution.
Huge caution. And for tropicamide, a useful tip is combining it with phenylephrine.
Using both together.
Yeah. You can get an additive Mydriatic effect, bigger dilation than either one alone. Can be really helpful sometimes.
Good combo tip. Okay, now the downsides, adverse effects. What can go wrong, starting with the eye itself?
The main worry, ocularly, is raising the intraocular pressure, the IOP.
How does that happen?
In people with narrow anterior chamber angles, the drainage angle in the eye, a dilated pupil can bunch up and block the outflow of aqueous humor. It's called pupillary block.
And that spikes the pressure.
Can lead to acute angle closure glaucoma, which is why we absolutely avoid mydriatics in patients known to have, or be at high risk for, angle closure glaucoma. The source really stresses this.
Makes total sense. Don't want to cause an emergency. What about side effects elsewhere in the body, systemic ones?
Well, with atropine, because it's anticholinergic systemically too, you might see tachycardia.
Fast heart rate.
Yeah. And with phenylephrine, being a sympathomimetic, it can potentially cause hypertension.
Raise blood pressure.
Exactly. Which just highlights why you need a good patient history. Monitor vitals in susceptible people and always use the lowest effective dose.
Right. And what about that blurry vision everyone complains about after dilation?
Yeah, the most common one. That's mostly the cycloplegia.
To ciliary muscle paralysis.
Right. Can't focus properly, especially up close for reading. So vision gets blurry.
But it wears off.
Oh, yeah. Important to reassure patients it's temporary, resolves as the drug wears off within that duration we talked about.
Okay. So key adverse effects. Potentially higher IOP, maybe heart rate or BP changes, and that temporary blurred vision. Got it. Now, contraindications. When should we absolutely not use these?
Okay, absolute contraindications. Number 1, angle closure glaucoma. Big no-no. Risk of that acute IOP spike.
We covered that. What else?
Also, any known hypersensitivity, allergy to the drug itself or any component in the formulation. Like some phenylephrine drops have sulfites. If someone's allergic, you can't use that specific one.
Okay, angle closure and allergies are absolute. What about relative contraindications, where we need extreme caution?
Relative ones. Using atropine in people with Down syndrome.
Wow.
They can have an exaggerated systemic anticholinergic response. And phenylephrine should be used very cautiously if someone has severe or uncontrolled hypertension.
Because it might raise BP even more.
Exactly. Only if the benefit clearly outweighs that risk.
Crucial safety points. What about drug interactions? Anything we need to watch out for?
Yeah, a few important ones. Anticholinergic drops plus TCAs, tricyclic antidepressants.
What how?
Increased risk of systemic anticholinergic effects, like confusion, delirium, urinary retention. Adds up.
Okay, what else?
Phenylephrine plus MAOIs, monoamine oxidase inhibitors. Big risk there.
What kind of risk?
Hypertensive crisis. Dangerously high blood pressure. So avoid that combo.
Definitely avoid. Anything else?
Beta blocker eye drops might potentially blunt phenylephrine's dilation effect a bit. Less of a crisis, more of a reduced efficacy issue.
So always need that good medication history before starting these.
Always. Paramount.
Our source had an exam tip, too. What was that key point?
Yes. The tip was about atropine and heat stroke.
Okay.
Atropine can actually worsen hyperthermia, make the high body temperature even worse in someone with heat stroke. So avoid it in that situation.
Wow, that's specific and important, especially in hot climates or certain situations. Good tip. Let's get into specific dosages now and maybe more clinical pearls.
Sure. For atropine 1% drops, typically 1 or 2 drops, often used before surgery or for that strong cycloplegia in kids we mentioned.
Okay. Tropicamide?
Tropicamide, 0.5% or 1%, again, usually 1 to 2 drops. Very common for routine fundus exams.
And phenylephrine, you mentioned different strengths.
Right. Generally recommend using the 2.5% strength if the patient has hypertension or cardiovascular issues.
Why not the 10%?
The 10% has a higher risk of increasing blood pressure systemically. So 2.5% often safer in those patients.
Good practical advice. Any specific pediatric notes?
Yeah, just to mention cyclopentolate 0.5% again. It's another anticholinergic, often used in kids as an alternative to atropine if you want cycloplegia, but for a shorter duration than atropine provides.
Useful alternative. Okay, dosage points covered. What if things go wrong? Toxicity or overdose? How do we spot it and manage it?
Recognizing the signs is first. For atropine overdose, flushing, delirium, fast heart rate are classic.
And the fix.
The antidote is physostigmine, given carefully under medical supervision, plus supportive care.
Okay. And phenylephrine toxicity.
Signs would be severe hypertension, maybe cardiac arrhythmias.
Management.
Management involves using phentolamine, that's an alpha blocker, to counteract the effect, plus supportive care like IV fluids.
So specific antidotes exist. Good to know. The source also mentioned black box warnings. Any critical ones there?
Yes. For cyclopentolate, there's a black box warning about the risk of psychosis, especially in children.
Psychosis. Wow.
Yeah, serious behavioral changes.
Yeah.
So imperative to use the lowest effective dose in kids and monitor them closely for any mental status changes.
Really important point for PEDs. Anything else?
Phenylephrine 10% solution is contraindicated in infants.
The strong stuff. Why?
Risk of serious central nervous system depression in infants. So big no-no for the 10% in that age group.
Okay, serious warnings. Careful dosing and patient selection are key, especially in kids and infants. Now, the high yield fact from the source.
The high yield fact was about aproclonidine.
What about it?
It's an alpha-2 adrenergic agonist, and it can actually help reverse those temporary spikes in eye pressure that sometimes happen after using Mydriatics.
Oh, interesting. So it can help manage that potential side effect.
Exactly. A useful tool to have in the back pocket if IOP goes up post-dilation.
Nice tidbit. All right, let's wrap up with the final exam checklist. A quick run-through of the absolute must-knows, especially for you folks starting with KMR Advise.
Let's do it. First, mechanism of action. Know the difference. Anticholinergics block M3. Sympathomimetics activate alpha-1.
Got it. MOA clear.
Second,
Contraindications. Absolute ones. Angle closure glaucoma for all. Uncontrolled hypertension specifically for phenylephrine.
right, avoid in those cases. Third,
Adverse effects. Key ones. Ocular is increased IOP. Systemic are the anticholinergic effects like tachycardia with atropine or adrenergic effects like hypertension with phenylephrine. And blurred vision from cycloplegia.
know the risks. Fourth,
Reversal agents. Remember the antidotes for toxicity? Physostigmine for atropine, phentolamine for phenylephrine.
physostigmine, phentolamine, got it. And last, monitoring. Always monitor IOP in glaucoma suspects.
Yeah.
And watch carefully for systemic symptoms, especially in children.
Monitor, monitor, monitor. Fantastic summary. So as you can clearly see, really understanding ophthalmic mydriatics is, well, essential.
Non-negotiable, really.
Yeah, for anyone going into medicine, this knowledge, everything we've discussed in this deep dive, you'll use it. It's directly applicable in your future clinical work.
Conducting eye exams, helping in surgery, managing conditions.
Safely and effectively. So if you found this session helpful, especially for your learning journey with KMR Advise, please do share it.
Pass it along to your classmates, your colleagues.
And make sure you subscribe to the KMR Advise YouTube channel. There's more great educational content there.
Definitely hit that subscribe button.
And click the bell icon. That way you won't miss any future updates or deep dives like this one.
Absolutely. And, you know, medicine keeps evolving. Our understanding of even these drugs continues to deepen.
True.
So always stay curious, keep learning, and always, always aim to give your patients the absolute best care.